in medical nutrition therapy. On behalf of entire Venki's Nutrition, in association with IAPN, we are conducting this exclusive webinar on a subject that is cancer cachexia, understanding its metabolic paradox beyond calories. This webinar is just part of ongoing effort, and we are organizing this session because we truly feel that topic like cancer cachexia need a deeper discussion, better understanding, and practical action in day-to-day clinical practice. Today's topic, cancer cachexia, is extremely important, and as you know that cachexia is not just about weight loss; it is a serious metabolic condition that affects survival, treatment tolerance, and quality of life. We are very fortunate that IAPN has given us opportunity, platform to share the knowledge with the expert, Dr. Souvik Chakraborty from Kolkata, a well-known expert who is deeply involved in supportive care and clinical nutrition. His practical approach and strong clinical experience will surely help us, all of us, to manage our patient better. So all participants, just to brief about Dr. Souvik Chakraborty is having a very good academic credentials and very expertise in this nutrition segment. He has done PhD in nutrition science. He
All
is a certified diabetic educator, and he's completed a bachelor in pharmacy, completed MSc in dietetics and food service management. He pursued postgraduate diploma in management from Symbiosis Pune, completed postgraduate program in clinical nutrition for adults under USA Academy of Family Physician. He is certified sport nutritionist. He has got a vast experience and various awards, like he is awarded as a best nutritionist by Indian Army in 2018. He is a recipient of Star Galaxy Award 2023. He is formally associated as a founder member of Med Johnson Nutrition India Launch Project. He worked for Pharmex Germany 2007-8. He worked in medicine manufacturing unit of Days Medical Limited Kolkata. He worked in parenteral tablet and syrup section in Emson's Pharmaceutical Limited Kolkata. Presently working as a faculty member of defense related studies in defense establishment, and he is a guiding light for sport nutrition to international, Olympic and national games for all age groups in association with some reputed sports academy in Kolkata. Having a vast sound academic profile and having a vast experience, we are very privileged to have today our guest Dr. Souvik Chakraborty. I welcome Dr. Souvik Chakraborty for this session, and I'm handing over this session to you, sir. Please, sir.
Thank you so much, Prasanna sir, and thank you so much,
Mr.
Venki's.
Prasanna, you are recording the session?
Yes, yes, it is in
Okay,
recording.
okay, okay, okay. Shobhi sir, continue.
Yes. Thank you so much, Venki's Nutrition, for sharing this platform as well as some academic credentials, and also some knowledge backups as well. That's why we are collaborating together with IAP in India and Community Nutrition Core Group as well for working further. So thank you so much, IAPN India and Community Nutrition Core Group Chief Program Officer Shaumendu sir and Renuvit Singh ma'am as well. So respected senior clinicians, oncologists, nutrition experts, and dear colleagues. So very good evening. So shall I share the slide?
Sure, sir. You can share this.
Okay. Okay. Thank you so much. I'm just sharing the screen.
I think Mr. Prasanna, you have to make Souvik sir co-host to present the
Okay,
slide.
just let me. Okay, okay, sir. Let me do.
Huh.
Yeah, yeah. I made it him co-host right now.
Yeah,
Yeah.
Souvik sir, you can now share the screen.
Okay, okay. Thank you so much.
Yes, the screen is being shared. You can straight away open your PPT now.
Yes. Is it visible?
No, it is not visible. You can try it again.
I'm just trying once again.
You click on the share option. There will be
Uh-huh,
enter screen. You click on
uh-huh.
that and then
Connected.
because if you share on your behalf, it will be more comfortable for you to present.
Mhm. Absolutely.
Sir, are you facing any problem in sharing?
Yes. In it is when there is a issue.
Okay, okay,
Okay, in the meantime, is it possible, Shaumendu sir, to share the screen or Fatma?
yes, yes. I am asking Sominder sir, but he is not picking my phone. Participant, please allow us 2 to 3 minutes, so we will solve this technical issue. Meanwhile,
Actually, Prasanna ji, आप अगर if is it possible, Fatma, for you to share?
sir has not shared me any PPT right now. So you have sir's PPT with you?
Acha, Fatma will be sharing. Souvik sir, Fatma will be sharing.
Okay.
Fatma, please share the screen if it is possible. Are you from the laptop?
Yes, sir, just give me 2 minutes.
Okay. Acha, Souvik sir, you try by that time Fatma is sharing on your behalf. Fatma Firdos, you have to again make one more co-host.
Yeah, yeah. I made her co-host.
Okay, she is sharing on her behalf.
Yeah.
Souvik sir, I think you have already shared now. So you can start a brief discussion about interaction with about cancer cachexia or whoever is working in the cancer setup, they can interact. By that time, we are taking 2 minutes to share the screen.
Yes, yes, sure. Okay. Just a second. Please allow me just 30 seconds. I will just try once, then I'll just start. Is it okay?
Yes, sir. Already you have shared once. एक बार आपने share किया था. You have shared once. So you can, if you try, I think you can.
Yes, yes, yes. Yes.
Fatma, are you there? Otherwise, I will share on my behalf.
Yes. But
Fatma has shared.
Now it is visible.
yes.
Yeah. Yeah.
Make it full screen, sir.
Thank you
Yes,
so much,
now it is
Fatma.
visible.
Thank you so much, Fatma, for sharing your screen. So there's a technical difficulty I'm facing. So okay, let's start. So once again, thank you so much, Venky's Nutrition, for giving this opportunity to join hand collaboration with IAPEN India and all senior clinicians and oncologists, nutrition experts, and dear colleagues. Very good evening. I sincerely thank you, everybody, for joining in this session and giving me the opportunity to share my thoughts on the topic that we all encounter frequently in practice. You still find extremely challenging in cancer cachexia, right? So, despite advance in oncology, many of our patients continue to lose weight, strength, dignity, and sometimes treatment tolerance as well. Not due to lack of food, but due to altered metabolism. These tell us clearly that cachexia is not starvation, and calorie alone are not the solution. Okay, this is our challenge today to show give some light into it. Today, my humble attempt is not to present something revolutionary, but to connect pathophysiologically and the practical nutrition supported by evidence, and finally show how protein, essential fatty acids, and eicosapentaenoic acid and the palliative care together can meaningfully change the outcome. So, thank you for changing the slide. Fatma. So, cachexia is a complex metabolic syndrome. Okay, here is a case. The patient came to me 1 year back. He is 58 years old male and diagnosed with stag to non-small cell lung cancer, and he was on chemotherapy. So his weight loss was 9.5% in 3 months. So baseline BMI was 18.2 kg per meter square, and performance status is ECOG2. That means he was chemotherapically, he was halfway active. That means he can walk but not can join the work. Okay, the professional work. So key symptoms are anorexia, early satiety, fatigue, and muscle weakness. So his diagnosis was cancer cachexia characterized by elevated CRP, because CRP level and albumin level decreased, reduced muscle strength. How we can identify the muscle strength? By hand grip strength monitor and many other monitors. So strength and lean body mass. So nutrition and palliative intervention. So that's how we can understand something about this nutritional and palliative intervention we can do. So nutrition and palliative interventions, the protein we have to set 1.5 to 1.8 gram per kg per day, and obviously we have to enrich the leucine, and small frequent feed is very important, because we cannot eat large amount of protein at a time at the cachexia level. So for that reason, maximum 15 grams of protein can be absorbed at a time. So we have to understand all the things together. So how we can set this goal? We have to understand by the entire slides together. So eicosapentaenoic acid 2 grams per day. Why eicosapentaenoic acid? Because this is the anti-inflammatory and anti-catabolic nutrition, and energy level is 30 to 35 kilocalorie per kg per day, and obviously this is fat enriched. So if it is fat enriched, the maximum calorie got into fat, so feet can be smaller, and symptoms are symptoms guided. Obviously the palliative care, appetite stimulant stimulation can be given, the pain and nausea control can be given, the physiological and family support, all are symptomatic care can be given. Okay, and what is the outcome after 2 3 months? We can see some certain of weight gain like 2.1 kg, which is almost 1%, 2% of total body weight, and lean mass is stabilized. That means some muscle strain has been visualized and hand grip strength slightly improved. CRP level, it can be reduced because of this chemotherapy and this condition. The CRP level was very high. So after 2 3 months, we can see that day by day, month by month, the CRP level got reduced. Improve appetite and chemotherapy tolerance is visible. So key clinical message. So we have to identify the cancer cachexia is metabolic and inflammatory condition, right? So it cannot be managed on calories alone. So overall, we have to count the calories. This is important, but as well as we have to ensure the quality of protein, EPA, the energy, how energy is distributed, the palliative care, all are very important, and counseling, psychology counseling is also very important. So hand grip strength increase. So after that, we can understand the combined approach, adequate protein, EPA supplementation. Why supplementation? Because in the food we cannot supply maximum amount of nutrition at a time. So that we have to include some amount of supplementation which can ease their making a diet plan or menu planning very easily. And the palliative care improves the functional outcome and quality of life, obviously. So we can now have to identify each and everything in a very specifically. Okay. So we have to identify cachexia. Cachexia is a complex metabolic syndrome. It's characteristic by muscle loss without fat loss. What is the important here is to distinction. And cachexia is biologically different from starvation and depression or aging related sarcopenia. So this is not age related sarcopenia. We have to identify that, and mainly, we have to identify if the food only, medicine alone, could fix ataxia. None of us would be discussing it today, right? Because only food and only palliative care, only exercise, only medicine cannot make it happen. Okay, we have to understand it very vastly. We have to focus each and every point. So, anorexia, inflammation, insulin resistance, and increased muscle protein breakdown are frequently associated with cachexia. So, cachexia is distinct from starvation. It is always been said. So, it is not age-related loss or muscle mass. Primary depression and malabsorption of hypothyroidism is associated with the increased morbidity. So, Padma, can you please pass on the next slide? So we have to focus on two cells. Okay. One is normal cell, one is cancer cell. So we have to understand the biochemistry or between the normal cell and the cancer cell. It is a glucose converted to glycolysis, convert to pyruvate and lactate in normal cell. But in case of cancer cell, it lactate is forming, then the having in it, it cannot be converted to ATP or energy production. So we can identify the malignant cell and normal cell, and the biochemistry itself is a quite different. And based on this cancer cell cachexia, the glucose hunger is seen because of these biochemical changes. We can change, Padma.
Padma, can you just stop and share again? Hmm.
So weight loss in cancer is multifactorial. Tumor burden, inflammatory cytokines, altered hormones, and reduced intake of all contribute. But dominant driver is inflammation induced muscle breakdown. So we have to identify, so why do cancer cell activate glycolysis despite of presence of oxygen? Oxygen was there, still the cancer cell activate glycolysis. So generally we can see in spite of having oxygen, it is not there to start the glycolysis, but assure ATP synthesis when tumor outgrows its oxygen supply, the metabolic intermediates of aerobic glycogenesis provide raw material for the synthesis of cellular components in these rapidly dividing tumor cells and also favor tumor growth. Related to acid lowers the extracellular pH, which favors tumor invasion and suppresses immune efforts. So we have to identify the tumor cells are obviously a different biochemical process are there. So can you please share the next one? So can you please share the previous one again? Yes, thank you so much. So overexpression of hypoxia, includable factor 1, HIF1, it increased transcription of many genes, and this convert the code protein favoring cancer. So it alters the glucose metabolism and apoptosis resistance and angiogenesis. So these three factors has been done by the codes protein favoring cancers. Okay, Padma. Yes, thank you so much. So chronic illness, we have to identify the chronic illness like heart failure, chronic obstructive pulmonary disease, chronic kidney disease, chronic infection, sepsis, cancer. So we have to identify the anorexia and inflammation and insulin resistance and hypo uh, anemia and hypogonadism. All are the symptoms. So in case of anorexia and inflammation, we can ensure the fat loss, and in other cases we can encounter the muscle wasting. So in fat loss, there is a cachexia diagnosis we can do by weight loss or at least 5% in 12 months of loss. And in that case, so decreased muscle strength, fatigue, anorexia, low fat mass index is visible, and abnormal biochemistry is also visible. So cause of weight loss is basically starvation, pure protein deficiency, and conserve lean body mass, deplete fat mass, and sarcopenia and cachexia. All three things together, we can have this entire loss of our mass, body mass. So body weight loss is characterized by three things together, like sarcopenia, starvation due to lack of our protein deficiency, protein absorption, and cachexia is cytokine mediated inflammatory disease. So we have to identify the mechanism of age-related muscle wasting. Fatma, next slide, please. Yes. So cachexia is characterized by starvation, point inflammatory cytokines, hypermetabolic states, and it decrease the muscle mass, decrease the strength, and neurodegenerative disease has been formed by sarcopenia and disability and age-related hormones and genetics. So there is a continuous complication for nutrient between tumor and host. The tumor behave like a metabolic parasite and creating hypermetabolic energy inefficient states, as described Thomas L. in clinical nutrition. So cachexia, definitely, we have defined earlier. The cachexia is defined distinct clinical symptom where activation of point pro-inflammatory cytokines has a direct effect on muscle metabolism and anorexia. Okay, next slide, please. Okay, so this slide is explains why appetite stimulates alone. Okay, when the inflammatory cytokines suppress the orogenic pathways and activate angiogenic pathways. So the cancer, we have to pathogenesis of case. We can identify the nausea and vomiting, anorexia, and metabolic changes we can encounter. So in that case, we can encounter the weight loss, then neoplastic cachexia syndrome. In addition, the complication of nutrient between tumor and host lead to an accelerated starvation state and characteristic by severe metabolic disturbance and hypermetabolism resulting in an increased energetic inefficiency. In this case, we can identify the ghrelin improves appetite and meal appreciation, but appetite involvement does not automatically translate into a lean mass gain. Hence, appetite is necessary but not sufficient. In anorexogenic neuropeptides, it ghrelins effects. Basically, it decreases the food intake, increasing resting energy expenditure. So in that case, we can identify the lack of food intake and wasting is the associated with this issue. This is a supporting study of ghrelin increased energy intake. Next slide, please. There we can find the ghrelin increased energy intake is a cancer patient with impaired appetite, acute randomized placebo controlled trial. We have done a trial with saline and ghrelin. So in case of ghrelin, we have found the better result and a marked increase in energy intake was observed with the ghrelin infusion compared with the saline control. And every patient reported food intake increased. The meal appreciation score generally graded by 28.8% with ghrelin treatment. So It was a study by J. Klein in the year 2004. It's long back. So we can come to the next slide, please. So based on this treatment, we can identify the level of C-reactive protein, which are the factors have been decreased, like C-reactive protein have been increased. So after following this procedure, we can identify the C-reactive protein has been decreased and fibrinogen has been increased. So it is a control. The first one is the control and second one is not controlled. So in case we are having ghrelin, so we can get the control effect on C-reactive protein and the fibrinogen, pro-inflammatory cytokines, and leptin in advanced cancer patients. Next slide, please, Padma. Padma, next slide, please. So, Padma, next slide, please. Yes, thank you so much. So, in this classification of cancer, we can find in a type of carcinoma is endoderm of ectoderm, the tissue or cell of origin, and as example, we can have the epithelial lining of gout and a small cell carcinoma of bronchus. In case type হচ্ছে sarcoma and tissue or cell origin is mesoderm, we can find the example of osteochroma and fibrosarcoma, and the type is leukemia. We can find the tissue or cell of origin is white blood cell. Our example is acute lymphoblastic leukemia, and type is lymphoma, and tissue or cell origin is monocyte or macrophages. Example is Hodgkin disease. We can find the type of adenomas. The tissue of origin is tumors that come from glandular tissues, and for example we can find in thyroid gland and the pituitary gland and adrenal gland. They are often benigns also. Okay, so what should be our support in this system? So our supported goal of cancer cachexia, our primary goal should be support tumoral effects of treatment. So firstly, we have to take care of the tumoral treatment, then reduce the side effect of treatment. That means the symptomatic treatment of the patient. Then support overall wellness, including psychological counseling and palliative treatment also. And secondary goals are supportive immunity. And in secondary goals, we have to set reduce tumor promoting factors. So we'll be studying about tumor promoting factors that inhibits the metastasis of tumor progression and promote appropriate apoptosis as well. So what is the management of cancer cachexia? We have to identify the best management. Next slide, please, Fatma. The best management for cancer cachexia is cure the cancer. Next slide, please, Fatma. So, as this will completely reverse the cachexia syndrome, unfortunately, these remain in infrequent achievement in adults with advanced solid tumors. Fatma, next slide, please. Okay. The second option would be to increase the previous one. The previous one, please. The management of cancer cachexia. Yes. Thank you. Thank you so much. The base management for cancer cachexia, I have explained, it is to cure the cancer, right? As this will completely reverse the cachexia syndrome, as we can see earlier in the cases discussion. Unfortunately, this remain an infrequent achievement of adults in advanced solid tumors. Advanced solid tumors, we have seen it is not so frequent. So in the second option, we will be increased nutritional intake, right? Firstly, tumor management. Next is nutritional intake. But the large number of randomized controlled trials of nutritional intervention did not show significant benefit with regards to weight changes or quality of life. That means we have to focus on each and every points, like tumor tumor care, as well as we have to understand the palliative care and nutritional support, the palliative support, and secondary supports as well. So diagnosis part, we have to understand the property of glucose hunger. This property of glucose hunger is the PET scanning of solid tumors. And if fluorodeoxyglucose, a non-metabolized glucose derived of glucose, is used when it is preferentially taken by tumor cells and rapidly dividing cells. This is a diagnostic part in PET scanning we can find, and in therapeutics we can find numerous glycolytic inhibitors have been developed which can be potential anti-cancer drugs. So we have to understand this as well. So next we can have Fatma, next slide please. The emerging drugs with some effects. So we have tried the thiazolamines and colecoxibs, grelins, insulin, branch chain amino acid, BCAA, the oxidolin, and olanzapine. These all are latest development of drugs which have some effects, side effects, or some secondary effects sometime with this cancer cachexia. So, insulin treatment of cancer cachexia, we have given a study. We can see in insulin treatment in cancer cachexia, in effects of survival, metabolism, and physical functioning as well. So, I'm just discussing the result in the group of insulin treatment 193 plus 139 days total significantly stimulates the carbohydrate intake and decrease the serum free fatty acids, increase whole body fat, particularly in trunk and leg compartment, whereas the fat free lean tissue mass was unaffected. Insulin treatment improved the metabolic efficiency during exercise. It did not increase the maximum exercise capacity and spontaneous physical activity. Tumor makes his blood did not indicate the stimulates of growth tumors by the insulin. That means we have to identify the some amount of physical training, some amount of physical activity is associated with the which decrease the insulin resistance as well. So insulin is significantly metabolic treatment in multimodal correlation of weight losing cancer patients. So hence it has been proved. There is a study. There's so much different study with the thiazolamide, colecoxib, and the grelins as well. So grelin I have explained earlier, BCAAs. So each study stand for the treatment of medical treatment along with the nutrition therapy of this cancer cachexia. Now we can come to the tumor promoters. Next slide, please. So we have to identify there are some dietary tumor promoters. So excess fat, if we can increase the excess fat, the insulin is increased. This is a cancer protective is acts as a tumor promoters. So it increases the estrogens, it increases the oxidative stress, it increases the inflammation. So excess fat has to be diminished. Excess protein has to be demonized because excess protein also increase the insulin, increase the IGF-1 factor, and excess calories also increase the insulin. Excess omega 6 Excess omega 6 essential fatty acid also increase the oxidative stress and inflammation. So everything everything in limit can make it happen, make the tumor promoters decrease the tumors. And here is a study, a reversal of cancer related wasting. Next slide, please. Here is a study of reversal of cancer-related wasting using oral supplementation with a combination of beta-hydroxybutyrate, that means the arginine and glutamine as well. So, patient with the solid tumor who had demonstrated with the weight loss at least 5% were randomly assigned with the double bind fashion to either an isogenous control mixture of non-essential amino acid and an experimental treatment containing hydroxyl methyl butyrate HMB and L-arginine, L-glutamine. So, in the exact reason of the improvement will require further investigation. So we have examined this. So in case of this, look at this graph, we can see the after using these elements, after using this nutrient, we have got the significant improvement. HMB, arginine and L-glutamine. So we have got extremely good result after having this one. Okay. So after that, we can come to the conclusion. We can include these components in our daily food routine. So it is not always possible to add this nutrient in our daily diet. So we can have some supplementation in case. The supplementation should have these components which help in solid tumors reversal or reversal of cancer cachexia, reversal of inflammations, and CRP. Whatever the results are there, we have to reverse all the results together. It has happened also. I have shown you earlier in my first slide. So next slide, please. The promotion protectors, low fat, high fiber. This is the plan of action we have to set. The low fat, high fiber, adequate protein, adequate calories, whole plant food, and omega 3 and omega 6 ratio should be 2 is to 1 only, and physical activity should be there. Why physical activity? It increase the insulin and it decrease the insulin resistance in our body. So it all factor alters the estrogens level, it all factor altered the insulin level and growth factors, and inflammation has been reduced, and down regulation of oncogenes and up regulation of tumor. So upper regulation of tumor suppress genes, tumor suppress gene, it can be altered by all these plannings. So we have to promote these protections in case of cancer prevention. While making the diet plan, we have to identify each and every point, and based on the symptoms, we have to treat along with. So, firstly, we have to counsel the patient. If the patient is having those elements on adequate basis, don't increase it. So we have to identify if along 7 points are there, if the patient already having these 3 points together, we have to focus on the 4 points. So this is the additional nutrition part. So additional nutrition I will be sharing later on. So effects of branch chain amino acid on muscle atrophy in cancer cachexia is the next study. So branch chain amino acid are the natural amino acid with interesting clinically relevant metabolic effort. So, by interfering with the brain stereogenic activity, by inhibiting the overexpression of critical muscle proteolytic pathways, so we can identify if a person is having this BCAA, it increase the muscle health. Okay, so cachexia has been decreased. and the balanced amino acid mixture. You can identify the next graph, the BCAA. In case of BCAA, we can find the significant muscle growth, and without BCAA, branch in amino acid, we can have the muscle wasting. It is downward, it is going downward only. Okay, this is one study by Biochem J in 2007. This is a very pretty old study, but we are following this while making the diet plan and making the clinical formulas. Okay, so next we have to identify the stages of cancer based on the size of tumor, invasion, and lymph node metastasis. The stage 0, we can find this is a cancer cell with a bowel lining, the little risk of spread. Risk is less. The patient come with the stage 0 cancer, the carcinoma in situ, that means carcinoma not spreading. So we are having some assurance with the stage 0, and the stage 1 cancer grow through the inner lining up to the muscle wall, but no further. The stage 2 cancer has grown through the outer covering of the bowel wall. The stage 3 cancer has spread the lymph nodes as well. So we have to identify either the lymph node has been inflamed or having pain on lymph node. In this case, we can identify this is the stage 3, and stage 4 cancer that has spread other organs such as lung, liver also. Having the reports or clinical reports are there, so it can be altered by the effect of cancer. So stage 3 and stage 4 are vulnerable definitely, and stage 3 we can identify while counseling the patients. Next is the metabolic intervention. So based on the previous studies, we have identified the next slide, please. We have identified the metabolic intervention we have to do, like high calorie density feeding, improve lean body mass. Next slide, please, if it is possible. So high caloric density feeding, then low carbohydrate content. Thank you so much, Fatma. So high caloric density feeding. This improve the lean body mass and low carbohydrate content. That means simple carbohydrate has to be minimized because starve the tumor, feed the patient. We have to identify the carbohydrate or simple carbohydrate has to be low, and high calorie density we have to increase the fat amount to increase the calorie dense formula, calorie dense meal, and suggested composition of high energy is less than greater than equal to 1.2 to 1.5 kilocalorie per ml, and high fat is the 45 to 50%, and low carbohydrate. So suggested composition high protein is 18 to 20%. So 50% fat, total calories 50% fat, 20% protein, 30% carbohydrate. So this is basically a formula. We cannot complete this entire formula along with the oral feed or the kitchen feed at a time. So we have to depend upon some clinical formulas, some health drinks along with the kitchen feeds or diets. Okay, so we can come to the nutrition guidelines in protein metabolism. Okay, in protein metabolism, additional protein is required for regeneration, healing, and rehabilitation. Like 0.8 to 1.0 gram per kg is normal maintenance level, and 1.5 to 2.5 gram per kg is increased protein demand. If the protein losing atrophies, enteropathy, and hypermetabolism or extreme wasting we can fight, we can add this amount of excess nutrition or minimize the normal maintenance level for fighting with the cancer, as you can see in the picture. and the protein requirement based on albumin level. If the albumin level is 3.5 gram per DL, if the protein requirement is 0.8 gram per kg. If the albumin level is 2.8 to 3.5, so the protein requirement is 1.1 to 1.2 gram per kg. And if the albumin level is slightly changed from 2.1 to 2.7, the protein requirement is 1.2 to 1.5. And if it is less than 2.1 gram per DL, the protein requirement is 1.5 to 2 gram per kg. So while making the menu planning and diet plan, we have to we have to analyze based on the albumin what we have get in the clinical reports. So effect of protein and energy dense. There is a study related to effect of protein and energy dense in 3 fatty acid and enriched oral supplements on loss of weight and lean tissue in cancer cachexia and randomized double blind trial. So in that case also, N3 fatty acid, especially EPA, that is eicosapentaenoic acid, many processes anti-cachexia properties it can be shown. This trial compared to protein and energy dense supplements enriched with N3 fatty acids and antioxidants. It's isocaloric and it's isogenous control supplements for the effect on the weight and lean body mass, dietary intake, and quality of life in cachexic patient with advanced parenchymal cancer. The total 200 patients have been assigned and randomized study and 2 cans per day of E and C supplements for 8 weeks of multicenter randomized double-blind trial. So, in the result, in the next place, please. In the result, an enrollment patient means rate of weight loss is 3.3 kg per month. Intake of supplement was below the recommended dose. So, in case the patient with taking the minimal dose, that means the recommend below the requirement dose, the weight loss is high. If they are taking as per prescribed dose, the weight loss is minimum. If the patient is not taking the supplement, the weight loss is maximum. Okay, so intention to treat the group comparison indicates at the mean dose taken the enrichment with N3 fatty acid and not provide the therapeutic advantage, and both supplement were equally effective in arresting weight loss. So we can come to the next slide, please. Carbohydrate metabolism. So we can find the glucose intolerance, the insulin resistance, abnormal insulin secretion, delayed glucose clearance, and increased glucose production, and variability increased Cori cycle activity. Next, we have to identify another important nutrition, that is glutamine. It is a neutral and gluconeogenic non-essential amino acid. It's stored primarily in skeletal muscle 75% and 25% stored in liver and nitrogen carrier between tissues. It is a primary energy source for rapidly proliferating states. So may conditionally essential displayed in stress states, example sugary and sepsis and surgery and cancers, and appears to be synthesized in muscle tissues in substantial amounts. Plasma concentrate are quite high. Secondly, only alanine needed for renal acid base balance. So basically, glutamine is very important in while making a clinical formula for cancer cachexic patient. So while choosing the formula, we have to identify this glutamine is there in proper quantity or not, and this is also very important in making formulas in many other cases where muscle wasting is there related to this. I'm just mentioning. Okay, so glutamine for arthralgias and myalgial mode of action. So we have to identify the mode of action. how the role of metabolic stress states glutamine freely released from the skeletal muscle in state of metabolic distress, while at the time of distress metabolic so glutamine freely released from the skeletal muscle. And advanced malignant disease result in muscle glutamine depletion and weight loss. So in case of stress hormone induced decreased muscle glutamine concentration, even in healthy adults, and intercellular glutamine concentration lowered the more than 50% under metabolic stress. And glutamine is known to preserve glutathione concentration, and glutathione is needed for the intercellular redox status. So we can identify this glutamine is very important while choosing the right formula for the cachexia patient. So based on the stage of cancer, we can identify the every common ingredient is important, or we have to find any one of them can be omitted or not. So next component is leucine. It is very important for protein synthesis. As you can see, the protein degradation and the cardiac cachexia and maternal influence. In protein synthesis, we can see the muscle wasting in cancer cachexia, motor activities, and in case of protein degeneration and protein degradation, we can find is a there are some factors like autophagy and complaint activity, myostatic action. It is very important. And in case of cardiac cachexia, we can see the heart muscle loss, ventricular reduction, and well thickness. We can use the leucine is very important. Normal electrocardiography is the proteolysis, and maternal influence. You can see the maintain the cardiac mass in adult offsprings. And in case leucine is also very important factor while choosing our right brand or right products. Next slide, please. So our very important ingredient is HMB. HMB is metabolite and the amino acid leucine, and it is claimed to produce incredible muscle growth. HMB is not superior to leucine supplementation, nor produce exceptionally high muscle mass gain. So we have two studies. One is whey with HMB, another one is whey with leucine. So when whey with leucine has win the match, but in case whey with HMB is at par, but it is also very important. Okay, so nowadays adding HMB is a part is a we can find. So we have to identify HMB and leucine, both are very important. Only HMB is not so important, so leucine is more important than HMB. Now nutritional issues throughout the course of cancer illness. So first, prevention of malnutrition through nutrition. So malnutrition consequences, completion of therapies is the mucositis infection. And the malnutrition is advanced incurable cancer. Next to the terminal care, and malnutrition as consequence and complication of therapies. It causes surgery, radiotherapy, chemotherapy. It's a malnutrition as a risk factor for anti-cancer therapy. And malnutrition with progressive tumor growth. Prevention of malnutrition through nutrition. It is very important. So nutrition issues throughout the course of cancer illness, we have to encounter every issues. So we have to solve the issues to fight with these issues, fight with this cancer cachexia patients. So specific metabolic changes in the tumor host. So while studying the tumor cells, we have to identify the tumor host cell as well. So tumor host reveals abnormalities of lipid metabolism, increase the lipolysis, increase the oxidation of fatty acid. In carbohydrate metabolism, it increase the glucose turnover, impaired peripheral glucose disposal caused by insulin resistance, and protein degradation is high, and nitrogen depletion is high, and muscle protein synthesis is lowered. Okay, so these are the issues we have to encounter. Next, the cancer related defects in fat metabolism. We have to identify where to protein loss. It decreases the fatty acids and glycerol turnover and hyperlipidemia and decrease serum lipoprotein and lipase activities as well. So now we can come to the best bet, the complementary cancer therapies. So in the cancer therapy, we have to identify eicosapentaenoic acid (EPA) is very important while choosing the correct brand or correct supplementation, or in daily diet is very important to add on. Like omega 3s, essential fatty acid with potential role in inflammation, immunity, cachexia is very important, may help to decrease the cachexia, may improve the chemotherapy effectiveness and enhance the immune function. And downsides may have anticoagulant activity, so use caution in platelets in low the coagulation therapy. Generally, well tolerated up to 0.3 gram of EPA plus DHA, docosahexaenoic acid per kg per body weight per day. But diarrhea can be possibly side effects. And dose is minimum dose of 2.2 mg EPA per day, based to avoid coagulating complications. Two new products on the market are there, so we can continue with ProSure, Resure support, all of the brands we can recommend. Okay, effects of omega-3 supplementation. So if we can supplementation with omega-3, we can see the decreased rate of weight loss. Weight loss is minimized because omega-3 is basically, we will know very well, its anti-inflammatory property it's having, and maintain lean body mass, because in inflammatory property we can encounter with the weight loss, recurrent weight loss. To maintain body mass is important, uh, to stop the weight loss. Along with omega-3 supplementation, it improve appetite, because appetite is also caused by the inflammation part, and improve quality of life because of this all three above issues. If it is solving this, the quality of life increase, inhibit progress of cachexian cancer, inhibit proteolysis synthesis factors, and decrease fatigue, cytokines to variability tumor cells, cytotoxic for tumor cell causing anti-inflammatory property as a cytotoxic. That means it can reduce the tumor cells, may reduce the adverse effect of chemotherapy. So in case of chemotherapy, we can file we can see many cases of inflammatory property, either the skin, either the hair loss, either other issues of skin edemas or swelling or skin rashes because of this inflammation. So if we can use, we can add the omega-3 supplementation or select any brand along with the omega-3 supplementation. It can be helping to reduce the side effects of chemotherapy. So here is a study of EPA, eicosapentaenoic acid, the omega-3 fatty acid from the fish oils. Basically, fish oil is the very good source of omega-3 for the treatment of cancer cachexia. It is a review. Objective was to evaluate the effectiveness of safety EPA in relieving the symptoms associated with the cachexia syndrome patients with advanced cancer. Along with, it was also our objective to study the side effects with chemotherapy, and selection criteria was studied, was included in the review of the assure in oral EPA compared with the placebo to control randomized controlled trials, and the patient with the advanced cancer and either in clinical diagnosis of cachexia of self-reported weight loss of 5% or more. Those patients who have reduced their 5% of weight, in that case, EPA and omega 3 are very important. And data collection, we can see both methodological quality evaluation of potential and trials, and the data extraction we conducted by two independent reviews. So it was done by the Devi A. Bogan C. and Dean TP in the year 2007. Is a very old study. So, and EPA acid, eicosapentaenoic acid supplementation. The next study, please. Next place, please. The EPA supplement versus megasterol acetase versus both of the patient with cancer associated wasting, a North Central Cancer Treatment Group and the National Cancer Institute of Canada collaborative effort. Here also we can see the effectiveness of EPA. So they have given 421 assorted patients with cancer associated wasting randomly assigned with EPA supplement. So 1.09 gram administered plus placebo. Sometime in research studies, we are using placebos to the patients. Sometimes they are having some mental effects as well. So sometimes they are having some clinical effects. So to identify it is mental effect or either clinical effect, we are using placebo in case of study. So MA liquid suspension of 600 mg per day plus an isocaloric supplement they have taken, and they have given a very good result while administering this EPA. So, in conclusion, EPA supplementation, the next slide, please. In conclusion, this EPA supplement, either alone or combination of MA, does not improve weight or appetite more than MA alone. So, if the patient have been administered with megasterol acetate, so only megasterol acetate is not effective. The megasterol acetate, obviously the eicosapentaenoic acid has to be added on. Okay, so in the use of eicosapentaenoic acid along with any other substance, that can give very good result. Next slide, please. The Warburg purified the crystallized 7 of the enzyme of the glycogenesis. In these studies, he developed the use an experimental tool that has revolutionized the biochemical studies of oxidative metabolism. The Warburg manometer, which measured directly the consumption of oxygen by monitoring the change in gaseous volume. So, as we have studied in the first 2 3 slides about this oxygen, excess oxygen, so here is the experiment where, based on this oxygen monitoring, we can have the direct data. Okay, so first, next slide, please. The fast growing cancer cell will require more energy for their survival and proliferation. Therefore, cancer cell use primitive inefficient reactions and aerobic glycolysis to regenerate the considerate amount of energy. So, based on that, the mitochondrial dysfunction plays a causative role in Warburg effect. Okay, the cancer cell have less number of mitochondria, therefore they rely upon the insufficient glycolytic mode of ATP synthesis rather than respirations. So, this is a study. Thank you so much for your time and attention, and thank you everyone.
Yes, thank you, sir, for your wonderful session, basically on cachexia. And I request participant to please raise your questions so that it will be addressed. So you can write it on chat box, or you can unmute yourself and you can ask the questions so that Dr. Chakraborty can address the same.
There are several questions in the
Yes.
chat box. Souvik sir, if you like to take the
Yes.
questions in the chat box, or before that, anyone wants to unmute
From
and
chat box.
read your questions. Yeah,
I have a question to Souvik. Souvik, yeah, hi,
yeah.
this is Devalina here. You have shown one thing, one slide on
Hi.
based on albumin level, the protein requirement. Is it any guideline
Right.
or any source from that you are taking off?
Yes, this is also very not common. I also want to ask the same thing what Devolina is asking. Shobik, about the albumin level and protein.
Now, obviously, there's the guideline, and obviously, based on this guideline, we have made this.
Now, what guideline you have taken from this means what based on this is
Source.
means what is the source?
Okay, just let me open the slide once.
Mhm.
Uh, Again, it will be difficult for you to open. Fatma was sharing the slide. So Fatma, if you can help. By that time, acha, it is open now. Yes. Can you go back to the slide, albumin slide? I think the source was given, and there are a couple of questions in the chat box. After that.
Yes, fine. So, albumin, based on the albumin, the protein requirement is guided by the SPEN and the ESMOs
Oh,
clinical
this is
studies.
this is the ASPEN guideline, right?
SPEN guideline, yes.
Okay.
Based on the cancer cachexia patient should follow a higher protein diet, and based on that, we have prepared this.
Okay.
Shobik,
And
if
the
possible,
guideline
if you can
also it has been followed
share with
in
us.
our hospital as well, Army
Means
hospital.
means it's a ASPEN guideline. That is I wanted to
SPEN
know.
guideline, yes.
Okay. Okay. Thank you.
Welcome.
So, one of the very common question asked by Miss Shomi, that is about the sugar, though I have answered it, that sugar is bad for cancer patient or not. So it is bad for everyone. Simple sugar causes inflammation, but it do not have direct role in with the cancer. Shobik sir, can you see the chat box? Click on the chat
Yes,
box.
thank you, sir. We have food which increase. Sir, do we have any food which increase the appetite? Yes, there's a question. Thank you, sir. Do you have any food which can increase the appetite? Yes. So, first of all, we have in this case, suppose a patient come with very less appetite. So, we have to encounter some clinical observation like why this appetite loss is happening, because obviously the cancer cachexia, but we have to give frequent meal in very less amount, okay, so that it does not have any quick satiety, okay. And also in that case, some food which are, they're accepting the taste, which are also very important. But in the meantime, we have to identify the entire protein, fat, and carbohydrate should be at per the guideline. Okay. So choosing your food items, it is on your decision, and also the patient's likings as well. So sometimes patient like to have some food which are out of the box, okay, so we can have this one, okay, this will increase boosting the the moral up, and this will increase psychologically, this will increase the appetite as well sometime. So it is not very cure that very true that only food like utse or food like any karela or anything can improve the appetite at a time. Or sometimes it is important that some people having some belief that karela can improve the appetite, okay, So based on the counseling, you have to find, you have to write, you have to guide. Okay, this is the formula basically. Sir, apart from protein and vitamin D, what other food, herbs, kara, and other foods or supplementation can be given to improve
You
immunity,
can share the
hematology,
see the
cancer?
screen. You can see the screen also. Uh, I have shared the screen regarding my voice is audible.
Yes,
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 yes.
audible.
Achha, there is a question for ICU patient, weight 78 kg, height 155 centimeter on RT and respiratory failure. My question is how much calorie and protein? This is very much patient centric. It is only not decided about the
Yes,
height and weight. And about the IAPEN guideline, Souvik sir can tell also better that we gradually increase the calorie. If it is required 2000, so we have to increase very gradually with 25%, then gradually with the 50%, then 75, then we will try to reach the calorie and protein. And obviously, it will be very difficult to meet the quality of protein, that is 2 gram per kg, is very difficult to reach. So where awareness is important, oral nutrition supplement is important. Shobik sir, if you can take one question,
absolutely.
there are few myths I
Sir,
wanted to
I
ask.
need to ask one question, sir. Hi,
Yes,
this is
please.
Lisa this side.
Okay,
Hello.
please.
Hi, sir. Actually, I need to ask something that as you have already discussed about the role of leucine, but for the prolonged period of time, we know there are some overdosing leucine's effects. So, what's your call regarding this? Like, if we give too much leucine based or HMB based protein for prolonged period of time, does this affect in cancers, tumors, or something like that?
Obviously, the thing is that L-leucine, which is essential branch in amino acid, ঠিক আছে, like primarily recognized for critical role in stimulating muscle protein synthesis, right? And sometime what happen, prolonged use of unusual supplementation, or sometime we can find in two ways. Number one is supplementation of BCAA or L-leucine. So in that case, only L-leucine is not there. There are some additives, some adjuvants are there, some flavoring agents, some agents are there as well. So while consuming the L-leucine, we are consuming these other products as well for long time. Okay. So if the patient is consuming it very well, is having deficiency for long time, they can have this one. If they are having some symptomatic effects like nausea, vomiting, sometime they are having some gut issues, they are having some other issues along with these products, or while using any some kitchen based formula you can add. So this one also can be followed for a long time, but the thing has to be reminded very well that which product or which food is not usual to your lifestyle. Like you are staying in West Bengal, you are having this Bengali natural food for a long time, so it is genetically compatible with you. If any product you are using which is not compatible with you, you cannot use this for long time. This will not give you long term effects, long term good effects for long term. Okay, you have to give some break. Okay, you have to continue this, man, you have to break this as well. Okay, while any product which you are using from the childhood or by birth, you can add this one. Okay, this one can be taken for long time for life. But if any product which is new to you, which is not pertaining to your daily lifestyle, okay, so you can have this one for long time for having very good effect, but you cannot use for life. Okay, it has to be a full stop.
But sir, I
There are
just
few
want to
more
know what
questions.
is, uh, may I mean, I just want
Yes,
to
yes.
clear one thing out.
Yes.
Like, what
Hmm.
is the, should we continue for 6 months or 3 months? Because it has been seen there are so many companies also who provide
Hmm.
these sachet forms and doesn't have such additives
Right.
also for the patient. In case of branch and amino acids, that is leucine, isoleucine, and valine. So, like,
Hmm.
is there any guidelines where we could give only like 3 months, 6 months? Like, is guidelines like we have to stop within 6 months or 3 months, something like that?
Yeah, the two things you have to be in mind, that the dose is 1250 mg per kg per day. Okay, this is the dose form, and it cannot harm using for long term. Okay, these two things are very important, but parallelly we have to remind that, so this is external thing you are using, so there, and this is, there is no any product which are not using adjuvants or anything else. Okay, only components. Okay, if any product has been developed in a laboratory or developed in a company, developed in a factory, it has to be added anything. Without adding anything on raw material cannot be marketed. Okay, in drugs form. So while using dosage form or medicine form, it has to be added something. So for long term use, you have to stop sometime, then you can start once again. Okay, for 3 months or 6 months, I'm coming to this point. So some patient having after 3 months of using this product or using these special formulas, they're having some side effects or gut compromise issue, or sometimes they're having some other issues as well. So you have to stop that as soon as possible. And some people are using this for 6 months, then intentionally you have to break it down to 1 or 2 months, then you can start once again.
Thank you so much, sir.
Okay, most welcome.
There is one question: omega-3 fatty acid can be given in lymphoma patient with obstructive jaundice. I think there is no harm in giving omega-3 to the obstructive jaundice patient. It is obviously good.
Absolutely
And,
no issue, no issue
no
using this
issue.
omega-3 fatty acid.
EPA dose 2 gram per day, but can be increased to 2 to 3, 4 gram as per needed. Sir, is it possible to improve platelet and WBC in the
First of all,
MH
first of all, EPA 2 gram per day. But the
2
thing is
gram,
that
I
as per
think
guideline, we
it
are
is the
working
minimum dose. Minimum dose is 2 gram.
minimum
It
dose.
can be increased up to 6 gram as per the studies I have seen. Maybe I
Mhm.
am wrong or what, but in
No, no, you
2 to
are
pancreatic
you are
2.5
perfectly
cancer,
gram.
correct.
2 to
uh,
2.5 gram dosage, and there is
minimum.
no minimum.
Minimum
Yes.
2.5, right? And can be
Okay.
increased 2, 3, 4 gram as per needed. Absolutely, it can be increased, but based on guideline we are giving. So if you are planning to give more than that, you are planning to give above the experimental data, you have to take permission granted from the research team, and as well as it is based on the research, and you will be giving the data. Based on that, you are sending the things to the team, and they will discuss.
Okay. Thank you. Everybody can switch on the camera and over to the organizers
It
for the
is,
vote of
it
thanks.
is
And that
totally agree.
after that, I will just say one or two line about the organization IAPN.
So, I mean, your voice was not audible. I hope you handed over to me.
Yes, yes, I handed over to
Yeah,
you.
okay, okay, fine. So, thank you, first of all of you. Especially thank you to IAPN group for providing this platform and having association with Venky's Nutrition for this webinar. And it was really a meaningful session, engaging session. My thanks to Dr. Souvik Chakraborty for such a clear, practical, and insightful talk on cancer cachexia. You helped us to look beyond calories
Thank
and truly the metabolic challenges what the patients are facing. Your experience, simple explanation will surely influence the way many of us manage cachexia in our day-to-day practice. I like to thank you for all the participants who have actively participated and shown the patience since last 1.5 hours. We at Venky's Nutrition always eager to have a collaboration with IAPN, and we remain committed to supporting healthcare professionals for providing platforms for knowledge sharing session like webinar. And together we can definitely strengthen the role of nutrition, which is an integral part of treatment, and we can togetherly we can improve the patient outcome. That's I can say. And once again, I thank you to Dr. Chakraborty and IAPN group for providing this opportunity. Hope many sessions in future we will collaborate with each other, which will helpful for the improvement in the nutritional care. So that's it from my side. Yeah.
Thank you. Thank you so much, Mr. Prasanna. Thank you, Venkis, for organizing the session and collaborating with IPN India. The goal of Indian Association of Enteral and Parental Nutrition is to fight against malnutrition, and obviously we promote the advanced science evidence-based practice for the clinical nutritionist, and also in the hospital level as well as the community level. So apart from combating malnutrition, we fight against promoting evidence-based practical practices, professional educations and developments for the healthcare society. And we have also specialized webinars on critical care nutrition, oncology. We do in and different subjects we are doing every month. We advocate policies, even guidelines. There are we collaborate with ASPEN for triple L courses and research innovations, many things. So once again, it is a privilege to have this kind of session. And thank you, Dietitian Souvik Chakraborty, for a
Thank
brilliant session, an insightful session for the audience. Thanks a lot. So we can wind up the session for today.
Yes.
thank you.
Yes, yes, sir. Thank you. Thank you all participants. Have a good evening and good night to all of